I am not an OR nurse, but we do circulate our C-sections. So has anyone done a C-section before?
Yeah.
All right. What were your concerns with it? Just to start, or do you want me to just go over what we do?
Yeah,
All right, I'll
maybe.
explain the process a little bit. So, usually the incision is a low transverse incision, so you want to make sure that that area is shaved prior to coming into the OR. When they do come into the OR, I guess probably for you guys, they'll most likely be under general. Is that what you've experienced? Anyone that's had a C-section?
They're coming here, they're crashing through the door, so it's whatever they can get.
Yes, exactly. So most likely general. What you're gonna do is when you get them on the table, you wanna make sure that you place a wedge under their right side to do a left tilt. And then ground pad, obviously the SCDs, Foley's in. And then for your timeout, you wanna know how many pregnancies that they've had and how many deliveries they've had. So that's what we call their G's and P's. So it's patient is if they're a G2P1, that means that they've had 2 pregnancies, including this one, and they've had 1 birth. So we know that they're a repeat C-section. All repeat C-sections do need a type and cross, and all C-sections you want to note their type and screen, because we do need to send cord blood down for anyone that has O blood or negative blood. So O positive, O negative, and then the rest negative blood types. Likely if they're coming to you also, we'll have to send a cord segment. So the surgeon will clamp off both ends of the cord, and you'll send that cord segment down. You'll put a order in that says umbilical blood eval. And I wrote stuff down too, and I'll give it to Teresa. These are all the times that we know. So obviously we note the OR in time. If we do a spinal, we note that, or we note the start of the incision, that's the start time, and then we note the uterine incision. We note when the baby comes out, when the placenta is delivered, the end time, and the out time. The other thing that you wanted to do, you guys measure your blood loss at all for procedures?
Estimated.
You do an estimated?
We
Okay.
have the blue top canisters to do QBL,
Okay, yeah, 'cause
but
that's,
mainly we do estimated.
okay. We do a QBL. It is good to kind of get a very good understanding of the blood loss, because that's going to kind of let us know if the patient is stable or starting to hemorrhage. Most of our patients are young, healthy patients, so their blood loss is kind of like the start to letting us know that something is wrong. So we like to get that blood loss, that accurate blood loss. So if you can measure it, that would be good. The other thing is with your suction canister, if you because if they don't come in with their water broke, so their membrane's ruptured, then they have to break that during the procedure. You have to pay attention to the suction canister with the amniotic fluid in it. So when they break the water, note your amniotic fluid volume. And then at the end of the procedure, there will be the amniotic fluid and the blood loss, so you just subtract that to get your blood loss. Does that make sense?
So you just
So at
you
minimum, I
mark
would
the
do that.
canister?
We don't mark it, we just note it.
Okay.
So if they break the water or rupture the membranes, then we look, and there might be 400 in the canister. Then at the end of the procedure, there might be 1,000. So then we just subtract that. We know our blood loss is 600
Okay.
just from the canister. And then if you want to estimate the sponges and stuff, just to add on to that, that would be good. Because anything over 1,000 with continued bleeding is a hemorrhage. So, what else? And then at the end of the procedure, we do a fundal check. So I don't know, maybe that's something that, I know that you guys don't do that, so maybe that's something that the surgeon could do, just to make sure that the uterus is firm. before they leave the room.
Only after.
Can I just say, because a lot of people used to do it wrong, if
Yeah.
you're gonna do a fundal check, you have to take your hand, you have to support the uterus here down low, so you don't push everything out.
Absolutely.
Hold low, down on the pubic bone, like here, and then belly button top, you'll feel the fundus, and hopefully their spinal is still working. If they're general, you just do it quick and go. But sometimes you really have to push down to express the clots out, and you can normally get a lot out. Just froggy their legs and like really mash down, because once they're awake and that spinal's off, that shit hurts really bad.
Yeah, that's why I hesitate, like, teaching you to do the fundal check, just because I don't know how to get you to stay confident with it. So, if we can get someone that's done them before, that would probably be the most ideal. But in the case where you do have to perform one, exactly like she said, you would want to support the lower segment of the uterus and kind of, push down, which I can send you some information on that. We
That'd be
can
great,
find out
yeah.
too.
Yeah.
As far as charting goes, it's just all the charting that's in your like under the C-section case in the pre-op section, right? Have you guys done that?
No.
No.
Pre-op? We don't.
Or not pre-op.
So our
The
patients don't
intra-op.
see- our patients don't see pre-op.
Intra-op under the
Yeah.
under the
Yeah.
C-section under the C-section procedure. So it should populate everything that you would need to document. Does that make sense?
Yeah, like every other case.
Okay, just want to make sure. And then the other things that you will have to document would be the time that they broke the membranes and what color the fluid was. So it's either usually clear, bloody, or green meconium. And then you want to know your QBL or your EBL. So you want to document that. And then you have to document all the delivery information, so like the time of the baby, the type of C-section it was, whether it was a repeat or a primary, the delivering physicians, and that's all under the delivery information in the labor and delivery band, which I can also get that to Teresa too. So I kind of just wrote down everything here, and we can keep this in a spot. So at minimum, you just write down like the important case times, and then you can go back into the charting, because like you said, it's likely gonna be a crash section. So, any questions?
Is there a way to get the surgeons to pre-populate a plan? I don't think they have one for over here for all the orders of stuff they need, because last time I've done a couple, they just rattle off stuff at the end, we have no idea what they're talking about.
Oh, I do
For the
also have the
orders.
count sheet too.
The orders that they want, the blood they want, our techs don't, no one here knows how
Yeah.
to draw that blood either, so they really need to, we tell the surgeons they have to do it themselves.
Okay.
We tell them they have to do the fundus, because we don't know how to do that here.
Right.
So,
Okay.
but if we can get a plan for the orders, because they rattle off, send this for this, we're like, what are you talking about?
Mhm.
We've never put these orders in before.
Yeah. Okay. Do you usually know what orders they put in? Is it standard?
So not necessarily, like it depends, they may or may not send like the placenta, but likely if they come here, they'll probably want to. And for cord blood, like I said, it's gonna be just for negative blood types and O blood type. And then cord gas, you likely have to send in cord gas, but I can write all those orders down for you too.
Okay, and we should be able to find something maybe on the Tubes of You for like a video on how to do that.
On how to do what?
The cord blood, how to pull.
Yeah, so the cord blood, if you have a sterile cup on your table, the surgeon can just empty like 1 to 3 mLs of cord blood into the cup, and then you can just draw it up with the syringe, and then the circulator or the scrub tech would draw it up with a syringe, and then the circulator could just put it in a purple top tube and then send that down.
Okay.
Does that make sense? And then this is our count sheet, so I can give you guys this too to see the so you know the list of instruments. Do you guys have a C-section pack?
We have your C-section pack, and we have our C-section crate, which is on our count sheet.
Okay.
So-
Okay. All right. So you're good with that. Yeah. And then I did, just print out like what the documentation would look like for the delivery information, so I'll give that to Teresa too, just so you can see all the things that you'd have to document, whether we're sending a placenta, whether there was a nuchal cord, so that means that the cord was wrapped around like the baby's neck, who the doctors were, who the circulating nurses were, and the time of delivery, and the type of, section and things like that. I will say that as far as cord blood goes, I wouldn't even stress it too much if you don't get it, because the problem is that order has to be put in under the baby, and from my understanding, there was issues with getting the baby to be a patient, like a patient chart here. So, worst
They
case,
make
they would just have to draw blood from the baby and send that, because the cord blood is just to, for like the RH compatibility, that's what we're assessing, to see if, the patient's blood type is compatible with the baby's blood type. And then that determines if the mom will get RhoGAM or not. So, worst case, I wouldn't even stress about that, but you will want to send a cord gas, that's important, and you want to make sure you clamp off both sides. So that's probably the biggest thing. Yeah. Any other questions?
Who takes care of the baby at that point?
So nursery should, if a section is called here, nursery should come over. So they should be here from Bellevue to take care of the baby. The baby's out within the first 5 minutes of the procedure.
So typically for here, ED comes up. ED has the NICU, ED has the incubator. They will come up with their NICU trained nurse, or their neonatal pals, whatever it's called, trained nurses. They come up and they will take the baby after that. If nursery gets here by that point, great, but usually they're not here by that point.
Gotcha,
Usually it's the ED nurses,
Yeah.
and always make sure you tell the ED to make sure they bring extra extra O2 and med air tanks. Their machine does not hook up to our wall.
What about the supplies like, for instance, for prophylaxis, the footprint and stuff like that? They
They'll be able to take care of it when they get there.
Yeah,
We don't have any of that.
yeah, that's not like a priority. Yeah,
Okay.
yeah,
Thank you.
yeah. Anyone
Awesome.
else?
All right. Good.
Alright.
Thank you very much.
Yeah.
Thank you.